Niacin's role in lipid management is one of the most well-documented yet underappreciated aspects of its clinical potential. Long before statins became the gold standard for cholesterol control, high-dose niacin was a frontline therapy for improving blood lipid profiles. It effectively lowers LDL, bad cholesterol, and triglycerides while simultaneously raising HDL, good cholesterol, a combination of effects that is rare among lipid-modifying agents. What makes this ability even more impressive is the mechanism by which niacin achieves it. Unlike statins, which primarily block cholesterol synthesis via HMG-CoA reductase inhibition, niacin acts at the level of the liver to reduce the production of very low-density lipoproteins, the LDL, which are precursors to LDL. Specifically, niacin inhibits an enzyme called diacylglycerol acyltransferase 2, DGAT2, a key player in triglyceride synthesis. By reducing the liver's ability to form and release VLDL, niacin indirectly reduces the levels of circulating LDL cholesterol, since much of the LDL found in the bloodstream originates from VLDL particles after they've been processed. At the same time, niacin appears to decrease the clearance of HDL from the bloodstream, thereby increasing its levels. In patients with mixed dyslipidemia, elevated LDL, and triglycerides with low HDL, niacin addresses all three components, something few drugs can do simultaneously. Despite this broad effectiveness, niacin has largely fallen out of favor in mainstream clinical practice. The reasons are multifaceted, but they revolve mostly around issues of tolerability and perception. The most common side effect of niacin therapy, especially at higher doses, is flushing, a temporary redness and warming sensation caused by vasodilation in the skin. Though harmless and often mitigated with aspirin or extended-release formulations, flushing is uncomfortable enough to deter many patients. In contrast, statins are generally better tolerated, easier to prescribe, and have shown consistent benefits in large-scale cardiovascular outcome trials. As a result, statins have supplanted niacin as the primary lipid-lowering therapy, and niacin has receded into a secondary role, sometimes used in combination therapy or for patients who can't tolerate statins. However, this shift has come at a cost. While statins are effective at lowering LDL cholesterol and reducing cardiovascular events, they typically do not raise HDL cholesterol significantly, nor do they address elevated triglycerides with the same strength as niacin. This leaves a therapeutic gap, particularly in patients with complex lipid abnormalities or metabolic syndrome, where niacin could offer meaningful benefits. Moreover, niacin's ability to improve lipoprotein A levels, a lesser-known but significant cardiovascular risk factor, is unique among lipid therapies and remains clinically relevant in patients with elevated Lp(a), for whom few options exist. The decline in niacin's use has also been influenced by a few high-profile clinical trials, such as HMHI and HPS2 Thrive, which failed to show additional cardiovascular benefit when niacin was added to statin therapy. But these studies have been subject to criticism for their design, population selection, and failure to account for the specific patient subgroups that may still benefit from niacin. For example, the baseline HDL levels in these trials were already relatively high, leaving less room for improvement, and the additive benefit of HDL-raising strategies may have been diluted in populations already optimized on statins. What's often overlooked is that niacin doesn't just modify cholesterol numbers, it has pleiotropic effects, including anti-inflammatory action, endothelial protection, and antioxidant properties. These secondary benefits could be especially useful in patients with diabetes, metabolic syndrome, or a history of cardiovascular disease, provided that therapy is tailored and side effects are managed appropriately. In essence, the underutilization of niacin reflects a broader issue in clinical practice, the tendency to favor simplicity and tolerability over complexity and nuance. While statins are undoubtedly powerful and life-saving medications, their dominance has overshadowed the valuable role that niacin can still play in comprehensive lipid management. As personalized medicine continues to evolve, and as we gain more insights into lipid particle behavior and individual cardiovascular risk profiles, there may be a resurgence of interest in niacin, especially for patients who require broader lipid modulation or who have statin intolerance. Niacin's story in cholesterol management is therefore not a failure, but a cautionary tale of how medical practice can sometimes prioritize ease over depth. It remains one of the few agents that can shift all major lipid parameters in the right direction, and for those who tolerate it well, it offers a low-cost, multi-pronged strategy for reducing cardiovascular risk. The challenge moving forward is to recognize when this underused vitamin still has a place in the modern therapeutic arsenal and to not let its historical sidelining obscure its enduring clinical value.